All right, hopefully everyone can see my screen. Hello, everyone, and welcome to our live session today. I'm going to go over a quick starter presentation on our program and the various opportunities that we have. And if you've not previously attended our shadowing opportunities, then you're welcome to kind of learn more about our program and see if you'd also like to participate and volunteer here. So first off, I'd also like to say, again, if you haven't muted yourself, it's a great time to mute yourself now, just so that you don't distract from anyone who's speaking, or Dr. Chen. We do have closed captioning as a throughout, just to accommodate anyone who has any special needs or they needs just extra accommodations for various disabilities, or you just need some help kind of paying attention or listening to the words that we have to say. And if you have any ideas about how we can be more accessible, I know that Zoom is not always the best, then we are happy to receive any of that information at info@prehealthshadowing.com. You can save us as a contact just so that if you get any emails from us, that it doesn't go to your spam. And so you can never miss a session or any of our opportunities. So I just want to say that we are a student-led, minority-led, women-led nonprofit, and we're dedicated to helping various people in the healthcare field or pre-healthcare field and kind of gain access to educational resources, regardless of your demographics or your abilities or your locations. I just want to say that my name is Kira and I'm a volunteer here at Pre-Health Shadowing. And I want to thank you all for coming. So if you do want to stay in the loop and kind of understand how we go about our program, here is our Instagram, our TikTok, and our Twitter. We also have YouTube, and all of our recorded sessions will be on YouTube. And our website, of course, at prehealthshadowing.com, will have all of that information listed as well. It's always a good way to kind of keep in the loop, though, is to join our social media, and then also that email at info@prehealthshadowing.com will keep you in the loop for the email list. So since we are an international program, I do want to know, where are you guys all coming from? North Carolina, New York, lots of New Yorkers. North Carolina, California, Pennsylvania, Chicago, Michigan, Maryland, a lot of East Coast. Yes, yeah. California, Ohio. Okay. Wow, there's a lot of people here today. I always love larger sessions, especially with, great speakers like Dr. Chen. So since we are oh, I kind of skipped over this part, but since we are a pre-health shadowing company, if you are interested in being a volunteer through us, you're welcome to register on our website. It's a short little quick application process, about 10 minutes of your time. You can kind of point out your skills and your assets and see if our opportunities are good for you, or if you would do well with our opportunities. And we are 100% remote, which is one of the best parts about prehealthshadowing.com. We do have a leadership team. If you all are wondering if you want to join that, it is 100% remote. It is a few more hours than the volunteer opportunities that we have. And that's going to be through our website. If you want to learn more, there should be a link in the website. Zywan, I think, is posting those, thankfully. And you can go learn more about the leadership team. There's different various activities you can do, like the IT department, leading grants, fundraising. We even have, if you like design stuff, we do have digital design, our website, writing copy or kind of fixing up the pages. We do have IT and research. We do have different department heads and volunteer communication stuff. So there's kind of a role for everyone. And if we do not have the role, you're welcome to kind of make up your own role within pre-health shadowing. And you can learn more about that on our website. And we even have the link down here. It's prehealthshadowing.com, and you can say /contact/join. It's join our team, all in dashes. But if you want to do that, that's always welcome. If you have any questions, you can also just email info@prehealthshadowing.com, and you can ask all your questions. And there will be a few minutes at the end of this session if you do have questions about pre-health shadowing and kind of getting involved through that. Maybe doing something similar to what I'm doing or what Zywan's doing. but it's always a kind of fun thing. So, if you're a high school student, we do have an HTP. It's a high school training program offered through pre-health shadowing, and that's a leadership and healthcare education um, program of sorts. There are also abilities to kind of join or create your own high school clubs that will be affiliated with HTP, which is fun. There's also an interest form on our website as well that kind of will tell you and see how you can connect with college pre-health programs or fundraising for PHS, or you can organize resources and kind of see a different side of medicine through pre-health shadowing and getting people more aware of the healthcare field and different kind of aspects of what you can join. So, part of our mission is to promote diversity at PHS. And in order to do this, we've launched an initiative to have monthly panels to celebrate different demographics in the field of medicine. Some of the times these are bi-monthly, sometimes they're every few months. It kind of depends on how many people we have. But if you do have someone that you'd like to highlight their importance, and they kind of have some kind of important topic, such as racial disparities, LGBTQ health, sexism in education, there's so many different things that you can do in that realm. You're welcome to kind of email us and kind of nominate a future panelist or someone such as your teacher or your mentor or even your doctor that has helped you through some kind of disparity or problem in diversity. So we're always welcome for that. So if you know anyone, that's always fun to kind of recommend someone who's changed your life or shaped you. So, kind of lastly, one of my last bullet points is donations. We are a nonprofit and we are a student-run shadowing company. So we're offering all of our sessions completely free and a lot of our resources completely free. And that sadly doesn't really come with no cost. So we do have to pay for Zooms and all of our digital work and our website. And so we do humbly ask if you can donate that you do. There's a QR code that you can scan. And if you can't donate, either or, we do recommend or ask if you can kind of highlight this program or pass this QR code or our link around and have someone who maybe can make a difference with our program. That would be amazing. We do appreciate kind of anyone, even participants. And if you guys just showing up today is amazing, since we can have some kind of word of say from mouth and have more people that can either help or donate. And that's always amazing. So throughout the session today, drop any questions you have in the chat. Our co-hosts will ask them, or I will ask them during the Q&A. You're also more than welcome during the Q&A to just raise your hand, and I can also call on you, and you can speak directly with Dr. Chen. She's always happy to kind of talk through her kind of research or her slides even more if you guys have any more questions. So don't forget to you can just put them in the chat. We'll be noting them down so no one's questions are going to get skipped. There's no kind of benefit to waiting till the end to ask your questions. So I would just type away. And so then that will be done in the later half of the session. So lastly, take good notes. Our professional is going to go over their presentation and there will be a post shadowing assessment at the end of this so that you can get your digital certificate, verifying your hours, just so you know that quiz will be up a few minutes after session. At most, it's an hour after the session, but we get it up pretty quick, especially lately. So I wouldn't wait on that. But if you are having some technical difficulties in loading the quiz, it might be because it's not up yet. That does take a little while for it to be uploaded after the session. So if you have any questions on that, you can also email us. But again, I would recommend waiting 30 minutes to an hour after this session if you have any tech problems with that. They might most likely are because of that. And then lastly, cameras on, please. If you are okay with sharing your face, I always love seeing people's cameras and seeing everyone's kind of face and pictures up. It makes us a little community and a little bubble. I already see a lot of people's faces coming up. That's always amazing. Wow, I'm actually surprised there's so many people. Um, so now I'd like to introduce Dr. Chen, and we are extremely grateful for her to be spending her time, especially this late in the evening. I know that you're on the East Coast, so that's always a jarring experience. So I'd like to thank you so much for sharing, and you can share your screen whenever possible.
All right. Hi everybody. Let's get started. Um, so I'd like to, as I load up some stuff, so I like to sort of just get an idea of what level of education everybody here is. I heard high school students mentioned earlier in the intro. Are we high school, pre-med, um, college? Like what, if you can just put in the chat a little bit about what what I'm kind of talking to, basically. Okay. So a lot of pre-med, a few high school, so that's awesome. Okay. And is there anybody who's specifically interested in ophthalmology? And for those who don't know what that is, that's the eyeball. Um, it's something that's not often mentioned in medical school, and that's why I ask. Um, okay, we've got one. All right, a few. Okay. Working as a vision therapist. Okay, so that's probably more optometry. Um, Okay, awesome. All right, so well, I love to make this kind of interactive, so feel free to interrupt. I have the chat up, so I'm kind of looking at it as well. Feel free to ask questions in it or interrupt. I can honestly keep talking, so I can talk for as long as I need to. We can cut the slides short. I have some videos prepared as well in case we want to see those, surgical videos. So we can just kind of, you know, go through this. So anyway, so a retina specialist, that's what I am. So that's a subspecialty within ophthalmology. And so I'm a retina specialist, and I do medical and surgical retina. So that means that on a daily basis, I'm in the clinic most of the time, and a few times a month, I'm in the operating room doing retina surgery. So many of you might know that there's different places where a person can practice. You can practice in a private practice setting, which is the majority of doctors in the country. You can also practice in an academic setting. So that's basically tertiary medical centers, often affiliated with medical students, trainees, and then sometimes you can practice in sort of a mixture of both. I'm also a teacher, so I love talking to medical students, residents, and fellows. Fellows are folks that have finished residency but want to do additional training within specific specialty. So I love chatting with people. I love doing research with folks, and it's really something that brings me a lot of joy. I'm also a researcher, so I do mostly clinical research at this point. And the thing that I like about clinical research, in addition to practicing, clinical care, is that you're able to hopefully answer questions, which is always interesting. Like always have a curious mindset. You're able to answer questions, and you're able to, reach a larger population of people rather than sort of one-on-one on a daily basis. So I'll just give a one quick slide about sort of where I came from. So back in the day, a long time ago, I was actually an engineer. So I did computer engineering and math. I did a lot of that. I was almost a whole different you know, life ago, but that's what I did. So that's what I went to college for. And upon graduating college, I actually went to computer science graduate school at Carnegie Mellon. I was doing a lot of machine learning. I was doing cognitive neuroscience, but mostly I was doing a lot of programming and research. And somewhere doing that fairly early, it just wasn't sort of where I envisioned my life to be. I sort of looked into all sorts of different options about ways to use my computer science and sort of engineering background to do other things, eventually just kind of realizing that, you know what, it's probably better if I just kind of jump ship and actually do the other thing versus trying to leverage um, like a background that isn't directly applicable. So a lot of reflection, volunteer work, stuff like what you guys are doing right now with shadowing. And I ended up going into a post-bac program at Johns Hopkins because I basically didn't have any biology in college. If anybody knows Caltech, it's really not known for its biology. Well, actually, there's a lot of biology, but it's not required. All I did was model action potentials or something. That was like the 1/4 of biology that I did. Anyway, so I needed all those pre-med requirements and stuff. So I went to Johns Hopkins for that for about a year and then applied to medical school. somewhere in there, I did some volunteering work at a nonprofit for full time for a little bit, but eventually I ended up at Yale, and then residency, fellowship, and stuff like that. And finally, I'm here. So, you know, why do I think the ophthalmology is so interesting? Like, I think unless you have a family member or yourself, especially at your young age, that's had a vision problem, you probably take vision for granted. That's something that's very common because it's such an innate part of how we exist. It's our most dominant sense. It's by far, if you're able-bodied and you have all your senses, it's by far the largest sense that you have. It takes the majority of real estate in your brain. And it's just incredibly high resolution. It's just shocking how much information, if you kind of just think about it, how much information that you can process when you're kind of in your visual environment and you process that at an incredibly rapid speed in order to run away from that saber-toothed tiger or do surgery or whatever it may be. Additionally, if you do anything like sports or surgery or cooking or whatever, it also offers depth perception. So it allows you to sort of interact with your space in a way that that we can kind of take for granted. And also it's kind of this is something I found like an emotional connection. I think there's some research associated with that. It's like, people talk about looking into people's eyes and feeling emotion and things like that. So it's really a large part of our everyday life. And that's what makes vision so interesting and so profound, even though it's a tiny little organ. Let's see. It's also really important for well-being. There's more and more data kind of showing that. There's data that's basically showing that if the elderly get cataract surgery, it decreases their chances of getting dementia. It's definitely impacts economic and and professional impact. For a person to lose vision, not I actually knew somebody who was completely blind since he was a child in college, and he could do basically anything the rest of us could do. Like he traveled. He had a laptop that spoke to him in rapid speed. He watched movies with us. So I'm not saying like you have to have vision in order to have professional fulfillment or economic fulfillment, but for many people, it's actually it is very difficult for the majority of people to function in actually our modern day society without vision. And of course, mental health and general quality of life. I think if you talk to any of my patients, and I see a lot of patients with diabetic eye care, um, you know, they rather lose their toe or their finger, frankly, than their vision, or even their leg. If you ask people to choose, what would you rather lose? Just think about it. Most people will lose so many limbs before they want to lose their vision because it's just how we interact with the world. So anyway, started with medicine, then decided on ophthalmology because I thought it was really cool. And I'll show you some examples of what we do in ophthalmology. You can see that it's really a good combination of being in the clinic, as well as doing surgery. And it's a really good mixture of seeing longitudinal patients, so patients that you kind of follow for a very long time, basically, essentially forever, as well as solving acute problems. So it's really a good mixture of many clinical, many reasons why people choose medicine. And then eventually decided to focus on the retina specifically, and we can talk about that a little bit. The eyeball is a very small organ, but there's shockingly many subspecialties within ophthalmology. So within ophthalmology, you have the retina, and I'll show you what that is. It's a specific part of the eyeball. And you have cornea, you have strabismus, you have neuro-ophthalmology, you have oculoplastics, you have pediatrics. I'm probably forgetting something in there. Anyway, there's many subspecialties within ophthalmology. And I chose to focus on the retina because it was just, frankly, the most fascinating to me. Sort of from this point on, I have some kind of slides about what is the retina and sort of some of the basic diseases that you might see in the retina. So things that I might see in my clinic or surgery every day. Does anybody have any questions right now or anything that they, based on sort of what I said, or I'll pause for 5 seconds. Okay, I guess you guys are interested in the eyeball. So here's the eyeball, okay? Can you see my cursor or that's a no-go? You can see my cursor? Okay, perfect.
Yeah, we can see it.
So this is the optic nerve. This is the nerve that connects the eyeball essentially to your brain. And then this is eyeball. And you can see this will be the front of the, when you're looking out. And then over here would be your head, essentially. You can see there are many layers in the eye, and these are just sort of the major features within the eye. So you have the cornea, which is essentially the window to the eyeball. It's a completely clear in a healthy cornea sort of surface that's on the outside of the eyeball. And within that, and behind that is the iris, which is the color part of the eye. Okay. And shortly right behind that is the lens. And if you think about the eyebrow as a camera, which is what people often make that analogy, the lens is sort of what focuses light. So when you're young, basically, the lens is completely clear. And the lens actually has these little muscles around it and with little strings. It's actually one giant string, little strings that can cause the lens to sort of bulge and also flatten out. And that focuses light. And over time, as you age, that lens can become what's called a cataract. You might hear that often. It's basically the lens that used to be clear when we're young starts to get hazy. It starts to get dark and starts to get dirty. And you don't have Windex inside the eye. So basically the only way to treat it as you get older is to do cataract surgery, which is really the bread and butter surgery in ophthalmology and probably the number one surgery that's done in ophthalmology. And then behind the lens is a very giant, inside the ball of the eye is just a lot of empty space, quite frankly. It's filled by this mixture called the vitreous. It's a gel-like substance, but overall it's just empty space. And sort of coating the inside of the eye, okay, just on the inside lining of the eye is the retina, okay? And the retina is the neural tissue of the eye. It's essentially a part of the brain, quite frankly. And these, you can see the blood vessels which perfuse the retina. And the most important part of every part of the retina is important, but the part that often can affect vision the most, obviously, is the macula. The macula is just a portion of the retina, which is the center of the retina. And what happens is when you have light, if you see images out here, the light goes through the cornea, it goes through the pupil, which is the empty space between the color part of the eye, the iris, goes through the lens, and then it hits the retina. And then the neural tissue in the retina senses that energy, senses that whatever, and then sends it to the brain. And that's how you process information in a very crude description kind of way. Quick question. Oh, hold on. Does the macula affect the retina, which causes conditions like myopia? Oh, it was a direct message. Okay, perfect. So, there are different causes of myopia. Myopia is basically nearsightedness. So myopia is basically, if you just think of it, the eye is too long, okay? The eye is too long and it can be too long in multiple ways. And because it's so long, the light has to kind of like not, so if the eye is, if the eye is really short, then the light will focus on if the light is, okay, how do I explain myopia? So basically the light will focus on the retina at a certain point, okay? And you can change it a little bit by the lens. Now, if the eye is too long and then everything focuses the light in the same way as a normal eye, then it's not going to focus. It's going to focus in front of the retina, basically. So that's why people with myopia will need certain glasses in order to make the light focus on the longer eye. It's hard to explain, but basically the end all product is that the eye is too long, and it can be too long in sort of the shape of the eye, which can affect the retina, and those are called staphylomas. And it can be too long because the cornea is too steep. And it can be too long because, in some ways the lens is basically too fat. So there's different causes of myopia, basically, one of which is sort of the shape of the eye, which can affect the retina. So question, as a doctor, could you see the inside of the retina through the pupil? So, what is inside the retina? So the retina is a really thin piece of tissue, almost at its thickest, at the center part, the macula, which is, not the thinnest part, but a thinner part of the eye. It's about 250 microns. So a micron is 10 to the minus 6 meters. So that's really, really thin. And the retina by itself is actually clear. So when you're looking at the retina, you're really just looking at, blood vessels and clear stuff and disease. So when you're looking through the pupil and looking behind the eye, you are seeing the retina. You're not necessarily seeing through the retina, but you're seeing to the retina. And it's actually the only part of the neural system, aka the brain, that you can look at and examine without any type of invasive procedure. Like you can't really just look into the brain without making a hole in it. You can't really look at, you know, other neural tissue like that without causing some damage. And that's why, you know, if you go to an eye doctor, or you might hear about dilated eye exams and why they're so important for people with diabetes or people with other systemic diseases, because when you have disease in the body, you can often see it in the retina. And it's actually a way for you to sort of gauge how severe the disease is. Okay. Yeah, immune privilege, that's an interesting thing. You know, it's not that the eye doesn't have an immune system. It is privileged in a way that it's separated from the rest of the body, but it can definitely have inflammation, inflammatory infections and stuff still within the eye. How do blood vessels pop in the eye? I'm not sure what that means. So specifically, which part of the eye? So if you're talking about blood vessels in the retina, well, there are different causes. Sometimes the blood vessels can just pop because there's increased sort of valsalva pressure in the body. Sometimes blood vessels can pop because they're not healthy blood vessels. For instance, if you have diabetes and the blood vessels are just very fragile in general, they can pop and bleed inside the eye. There's also blood vessels that are on sort of the outside of the eye. I don't know if that might be what you're talking about. Like sometimes you can literally go to bed and wake up, and there's on the white part of the eye, which is the sclera, just the white part of the eye. And this is sort of essentially on the outside of the eye, okay? You can have this tomato ketchup-like appearance. And it can look really scary, but it's actually basically the most non-scary thing ever. It doesn't hurt. It goes away by itself. So sometimes the blood vessel can just pop because you rubbed it, or you had some type of trauma, or sometimes you just had a really, you know, big bowel movement, or strained, or picked up something really heavy that can cause increased pressure and the blood vessel on the sort of the outside of the eye to pop. So diabetes affect that? Yes, diabetes can definitely affect the eye, and that is something that I see very often, unfortunately, in this day and age. Diabetes is basically a disease, you know, you can define it in different ways, but it affects blood vessels. It affects large blood vessels, and actually affects small blood vessels mostly. So you have all these tiny blood vessels inside the eye, and it most certainly will affect those blood vessels and cause a lot of problems. And I'll show some examples soon. Can I explain the macula again? Okay, so the macula is basically a part of the retina. It's like the prime real estate of the retina. So, you know, if the retina is like Manhattan, the macula is maybe like, you know, what's that park called? Central Park? Is that what it is? And so on. Yeah, okay. So it's like basically Central Park. It's a location, it's a geographic location within the retina that has a lot of stuff. It has a lot of function. And it basically is the center part of the eye. You use your macula, you use this part of the retina to read, okay? The highest resolution is uses the macula. And they have all this retina sort of on the edges. You're kind of still seeing things. If I'm moving my finger, if I'm moving my finger right here, but I'm looking straight ahead, I can still see my finger wiggling, but I'm not using my macula to see it. I'm using my peripheral retina to see it. Okay, so that's the difference. The macula is what you used to see in the middle, and all this other retina is kind of like peripheral vision. So, Davi said if myopia is caused by nearsightedness. So I want to just clarify that myopia is not caused by nearsightedness. Myopia is nearsightedness. They're kind of the same. Nearsightedness is kind of a layman's term for myopia. And farsightedness is hyperopia. Okay, so those are just more medical terms. Hyperopia is when the eye is kind of small, and then myopia is when the eye is kind of long. And you can use different glasses to fix things. And then you bring up a really good point that I'm always kind of, you know, I must get tired counseling patients about this, but I shouldn't, because it's so, you know, it's so, why would they know? If a problem can be fixed with glasses, in my mind, as a retina specialist, It's not a problem, all right? So when you lose vision, you have issues happen in the eye that glasses cannot resolve. So glasses can resolve myopia and or regular, general myopia and hyperopia, but it cannot resolve things like macular edema, things that happen from diabetes or a retinal detachment. Those things cannot be fixed by glasses. Um, okay, perfect. So that's the eyeball. So here's a picture of the retina. Oh, it's a little off-centered here. Oh, so you can see this is the optic nerve. Remember that little stump that was poking out? Well, now we're looking through the pupil into the back of the eye. Okay, so we're looking through the pupil into the back of the eye. And you can kind of see this is the optic nerve. It extends behind and then goes to the brain. And then these are the blood vessels that emerge from the optic nerve. And you can see that these sort of darker ones, those are the veins in the eye. And then the lighter ones, those are the arterioles or the arteries. So it's same as the rest of the body. You've got blood vessels that sort of give blood, and then you've got blood vessels that sort of take blood away. Okay. Speaking of which, is the vasculature of the eye different in terms of pathology compared to the rest of the body? I'm not sure. They are blood vessels. They're microvascular, so they're probably, different than your arteries because they're on a smaller scale. So they might behave a little bit different, but overall they're blood vessels. They've got pericytes, they've got basement membrane, they've got all the stuff other blood vessels have. Can you explain why concave versus convex lenses are used? Explain the detail of the shape for each and how it works to correct vision. Okay, so I'm a retina specialist. I don't do glasses. I haven't done glasses in 10 years. So I'll do my best to explain, but if it's wrong, don't hold me to it. Okay. People come for glasses. I'm like, I don't do it. So basically concave, I'm not even going to try because if I mess up, this is on YouTube. Okay. So concave and convex glasses are basically used to correct, the eye is too long for myopia. So you need, I want to say it's concave. I don't know. I don't know. You need one of those lenses in order to adjust the distance that the light focuses. Okay. So one of those lenses, they adjust sort of how you focus light to make sure that it meets the retina. So it's used to basically correct for myopia and hyperopia. And no offense, if glasses can fix the problem, it's not a real problem for retina specialists. um, and then here's another view of the retina. This is a ultra wide field view. So you can see that here's the macula for the macula is tiny. This is the macula. This is the circle that is the macula. Okay. And within the macula is this tiny little area that's called the fovea. That's yeah, that's a tiny little area. That's where all the magic happens. And then you have all this peripheral retina down here, out here. So I just tossed together some diseases that you might see. Oh, first I want to talk about tools. So the one thing that's really fun about being in ophthalmology is that you get a lot of fun tools. If you're techie and you like, innovation and tools and stuff like that, ophthalmology is for you because we've got a lot. So one of the basic tools is OCT. It's basically the patient kind of sits here, okay? And then the technician takes pictures of the eye. And it takes pictures it can take any parts of the eye, but the majority, at least for my purposes, they take pictures of the retina. So how do you interpret this? You see all these little layers. It's almost like a layer of a cake. What it is that it's a slice through the retina. So think of it this way. We've sort of seen the eyeball in multiple different orientations, but now just imagine that this is a slice through the retina. Out here, it's basically the outside of the eye. And then in here, remember that cavity I said that's basically filled with a thing called vitreous? It's just empty space. This would be inside the eyeball. And this is the fovea. And then this whole thing is macula. It's basically a slice of the retina, allows you to see the different structures in the retina and see if there's any pathology. This OCT here is slam dunk normal. So this is what normal or disease-free eyes should look like. And it's almost like in this day and age, the OCT offers a better assessment of what's going on than often an eye exam because it's just so high resolution. About right, these are like a few hundred microns in thickness. It's very, very thin tissue. Oh, here's a kind of a description about how the cut is. So basically the cut is, you see the fovea over here? The cut is basically, I'm trying to use my hand, but it's like a cut like this. That's how it's cut through. And there's all these like different cells inside the retina. I'm not going to go into that because that's not exciting. And you have all these different layers that showcase different diseases. And then you can sort of overlay, this is the cellular structure. You can see like the cell, the structure in the retina is very well organized, and it's kind of corresponds almost one, well, not almost, but 1-to-1 to the OCT. Other things that we use are fluorescein angiogram. This is sort of, when patients, when I have patients that I want to do a fluorescein angiogram on, I kind of tell them, hey, sometimes you have a cough and you don't know what's going on, or you have some ideas and you need to look a little further. You get a chest x-ray or you get a CT with angiogram. So you need additional information to understand what's going on. This is kind of our way of getting additional information. It's this dye called fluorescein. You inject it into the veins and then you take a lot of pictures of the eyes, and it basically highlights the blood vessels in the eye. This is a fairly normal angiogram. So you see all the blood vessels kind of matches the other picture you saw before. But if there's disease, I don't know if I have any with disease, I might have some in the later slides. You might see blood vessels, you might see capillary dropout, which is when blood vessels aren't there anymore. You'll see distortion of the blood vessels. So you can really showcase a lot of diseases. And we use that, we use this a good amount in the clinic. So here's some, you might have heard these terms. These are mostly elderly people diseases. There's definitely pediatric retina and things like that, but this is a lot of what you see. So you have macular degeneration, diabetic retinopathy, posterior vitreous detachment, which is not really a disease, but a lot of people come in with symptoms for it. Retinal detachments, epiretinal membranes, and macular holes. A lot of jargon. And my goal is really for you to just kind of see what it all kind of feels like, not necessarily that you need to know what each of these are. So macular degeneration, does anybody know somebody who has macular degeneration or getting treatment for it? Maybe a grandparent. Oh, that's interesting. Usually somebody has somebody that they know with macular degeneration. It's kind of exploding because of the baby boomer generation here in the United States, at least, because it's a disease that really affects the elderly. Mostly, there's a lot of lifestyle factors, but the biggest risk factor is really age. Your race has Caucasians have a predisposition to it. Also smokers, that's the biggest modifiable risk factor that you can do. Like smoking. Smoking can really make macular degeneration worse. So as the name says, it's a degeneration. It happens as you get older. It's macular, so affects the macula, which is a center real estate, which is kind of sad, right? Of all parts in the retina to affect, it has to affect the prime real estate, which is what you use to read, what you use to recognize faces. People usually with macular degeneration, they always ask in clinic, well, I go blind. The word blind as an ophthalmologist is just not detailed enough. What does blind mean? To me, blind means no light perception, as in the eye receives no signal whatsoever. And typically speaking, people with macular degeneration do not go fully blind. They will, unless something else is going on, they will always detect light. And they probably will always kind of see hands moving, or maybe even be able to see fingers, but certainly not read at the end stage. Okay, but they can be considered legally blind. The definition for legally blind does not mean that there's no light. It just means that they can't, they can't really drive. They might need services for them to do activities of daily living. So here's some pictures of the macular degeneration. I hope you remember what a normal eye is. It's basically this thing without these little dots here. Okay, these little dots are called drusen, and this is sort of a progression of macular degeneration. Got a few dots over here. Typically, when you're at this stage, it's not affecting your vision very much, but you need to kind of follow it because it can get worse. And then here you can see that those dots have expanded. Okay, so this is a more advanced form. And then sort of as you go further, you can see that there's what this is basically, it's loss of tissue. This is advancement of macular degeneration. So that's sort of what I see when I look inside the eye, and I can sort of define disease based on exam. And then here's another spectrum of macular degeneration where there's actually bleeding inside the eye. So you can see there's a little bit of blood over here, okay? And then there's, quite a bit over here. And then there's a lot of blood over here. This eye, if I see this, you'll try to treat it probably with eye injections and even perhaps surgery, but the prognosis, if it gets to this, is not great. The prognosis is not great. Blood under the retina is very toxic. So how do you treat it? So the mainstay treatment is actually eye injections, okay? And I just want to put a caveat. We are sort of in a renaissance when it comes to eye injections these days. There are a lot of eye injections out there now. There used to be a small group of them, but in the last few years, they've really exploded and they keep exploding. So I'm not showcasing all the injections that are available. So essentially you do just what it says. You inject medicine directly into the eyeball, and you do this in the clinic. Okay, we do numb the eye. Patients mostly are fairly comfortable, but the hardest part is really they have to come in, because typically speaking, you're getting these eye injections on a regular basis indefinitely. There's really nothing out there right now that can cure macular degeneration. It is really something that is treated. Okay. So say someone has macular degeneration, they're getting these injections, they might get them once a month. And then if they're doing well, then maybe they're not getting them once a month. Maybe they're getting them every 6 weeks. And then maybe every 8 weeks. You sort of extend. Typically, we don't really extend more than 3 to 4 months because they can get catastrophic bleeding. But that's sort of the idea. Patients are getting these eye injections sort of indefinitely in the clinic. Oh, here's a picture. I got this off the web, but that's, you do put a little eyelid speculum, you clean it, and then you do it. I do a lot of these, okay? So it's really not that bad. Most patients, if you numb them correctly, don't even feel it, frankly. The other big thing that we see is diabetic retinopathy. It's really, I think, the two biggest things you see is macular degeneration, diabetic retinopathy. And diabetic retinopathy, it's really a disease that hits a younger population. It often hits people who are of working age. That's sort of the demographic that gets hit hardest. These are just some numbers I pulled, basically saying diabetes is taking over the world, unfortunately. And, millions of people 3.4 million estimated by 2050. And it's kind of an economic threat in some ways, because a lot of people with diabetic retinopathy are in their sort of working age, unlike people with macular degeneration who are retired. So these are some pictures of the spectrum of diabetic retinopathy. Again, diabetes is a disease of blood vessels. When the blood vessels don't work right, it causes bleeding. Okay, that's the bare minimum. What happens? You got leaky blood vessels, it causes bleeding, you can have swelling. So this is sort of the spectrum. You might have like a little dot, you might have a few more dots, and then here you have significantly more dots. And then in this case, it's more advanced. You see all these blood vessels that are forming. These are not normal blood vessels, okay? So when the eyeball is so affected by diabetes, it does not get oxygen. You can kind of think of it like that. It goes into an ischemic state. And ischemic states produce these growth factors. And this is almost like a way, and the growth factors produce blood vessels. It's almost like a way for the body to say, hey, I don't have enough oxygen. I need more blood vessels. But it makes these blood vessels that don't work very well. It's like a compensatory mechanism that's gone wrong. Okay, so you have all these new blood vessels that form. And these blood vessels are not good, because what they do is they're fragile, they can bleed. And then if they can also form scarring, and that is what causes basically blindness and diabetic retinopathy over time. Here's another picture. This is of blood vessels here, and then you can see blood vessels over here. And then, so if I see this patient, I'm like, dude, we got to get you treated, because this is bad juju's going down the road soon. And this is a picture of what happens if the blood vessels, somebody said if it pops. So this is what happens when one of those fragile blood vessels pop. Your eyeball, the eye cavity, the thing that I said was clear in the middle, like it's basically empty space. Well, that empty space fills up with blood, and then you can't see. Can this growth become cancerous? Uh, no, not diabetes. No, macular degeneration and diabetes would not become cancers. You can have cancer in the retina. You can have cancer in the choroid, which is behind the retina. So you can definitely have, have cancer, and we can talk about that if people are interested, but not in these two states. Once diabetic retinopathy begins, can it be reversed? So it's tricky, okay? Because treating diabetic retinopathy is multifactorial. One is the patient has to control their blood glucose and their blood pressure. They have to sort of either by themselves or their primary care person improve their glycemic state. And that is very hard to do. Like I'm not saying I'm not saying people can't do it. I'm just saying in my personal experience, if somebody has bad diabetes, I I don't want to say it at all because I want to keep hope, but it's challenging to find someone who's able to change their lifestyle in a way that they can fully reverse diabetic retinopathy. I just haven't seen it. Having said that, if you have mild diabetic retinopathy and you work really, really hard, I have seen it get better. Okay. Has it totally gone away? I don't know, but you can get to a state where it's maybe not affecting your vision as much. Additionally, if we keep giving eye injections for the eyes that qualify for eye injections, the eye injections actually have been shown to sort of decrease retinopathy. The question is, if you stop injection, will the retinopathy come back? So I don't have a good answer for that, but once it get to a stage where there's all that blood vessel happening, I think it's very hard for it to be fully reversed without significant repercussions. Is diabetic retinopathy basically an increase in abnormal blood vessels in the eye? No, that is one sequelae of diabetic retinopathy. And that's a sequelae from the fact that the eye enters an ischemic state. Other things that can happen to the eye include, and I don't think I have pictures here, but you can have basically macular edema. Edema is swelling. You guys might be familiar with pedal edema. So you have patients with like congestive heart failure and their legs, if you touch their legs, they have like the pitting edema. Okay, basically the body's filling up with fluid. So you can have that in the eye as well. You can have pockets of swelling, edema that's in the macula. Okay, so remember that OCT shape that's like this really smooth contour? Well, instead of the smooth contour, it's not like a mountain because it's swollen. Okay, and if that happens, then you have to treat that. It's a separate thing to treat. But when blood starts to gather, is it visible in the sclera? No, it is not. It's people can have diabetic retinopathy that's incredibly severe, and you cannot see it on the outside. And that's why it's very important to sort of get regular eye exams for people who are diabetic, because they may not know that they have diabetic eye disease until they have a symptom. And you really want to catch them before they have a symptom. So you can sort of counsel them on maybe better glycemic control, or you can counsel them on ways to monitor their diabetes, that if it gets to a point, like maybe we treat it before it becomes worse, because you can't tell from the outside. When the blood vessel form, does that block the macula, not allowing? Um, so the blood vessels form, it actually often does not form in the macula. The blood vessels actually form often around the optic nerve, and it forms in the mid-periphery, which is sort of just outside the macula. So typically, new blood vessels forming does not affect the macula. But if the new blood vessels form and they pop a blood vessel and you have all this blood in there, yes, that blocks the macula and you cannot see. Okay. Is there any fluid that surrounds the blood vessel, or is it just air? Um, so it's fluid. It's not air. It's fluid. It's this sort of thick gel-like substance. It's called vitreous. It's supposed to be clear, and it's basically fills the entire cavity of the eye. So I would call it a fluid if I had to choose between fluid and air. Are there specific causes of an edema in the eye? Does it vary if it's on the vessel? Um, so you know, so edema is basically swelling in the eye. So it's not, I'm trying to understand. The edema is not really well, I guess the edema is can come from weak vessels that are basically leaking the fluid into the eye. So you can have edema in the retina, okay? You can also have edema, which is just swelling, happen for other reasons. For example, trauma, or for example, inflammation. So you can have edema in the cornea that can often happen after certain types of surgery. So you can have edema sort of, um, not so much on the sclera, but on the conjunctiva, which is the tissue that sort of covers the sclera. You can certainly have edema there as well. Can some people be genetically predisposed to diabetes? I sure think I do think so. Yes, you know, if you can figure that out, I think that would be very helpful. But you know, in my clinic, I see a wide variety of people with diverse backgrounds, and it certainly feels like certain ethnic and racial groups just have it a lot worse than others. And it's hard to tell whether it's just general lack of medical care or that they're more predisposed. But you definitely see it's definitely a disease with a lot of disparities. Let me put it that way. Um, oh, here's another picture. This is actually a very beautiful picture. You can see this blood. It's kind of layered. This blood is kind of it's there, but it's behind the hyaloid. So it's actually quite pretty. Um, not for the patient, but and this you can see, this is a further downstream from having new blood vessels. You see all these new blood vessels forming? This white stuff here, this white stuff is scar tissue. So if you have a lot of new blood vessels form, then over time, if those blood vessels are not treated or eliminated in some way, you're going to get all this scar tissue. And this is what's going to cause vision loss because this scar tissue is going to cause the retina to detach. Basically, the retina coats the lining of the eye. It's very smooth. It's like wallpaper on the wall, right? If you have wallpaper and it's supposed to be there, it's nice and smooth. But if you wallpaper, you start taking a corner and peeling it off, then it becomes bumpy and it can peel off. Okay. So that's what this is. This is scar tissue. This is bad. And then you can also get glaucoma. You see all these new blood vessels form. This is the iris. This is the color part of the eye. So this is not part of the retina. But as the diabetic disease gets worse, you can actually have new blood vessel growth that's outside the retina, that's on the iris. And this can cause problems like glaucoma, essentially. I'm not going to explain what this picture is, other than the fact that this is the thing that this band that you're looking at here is one of the primary structures in the eye that predispose a person to having glaucoma, which is, technically disease of the optic nerve, but oftentimes the disease is introduced because the eye pressure is high. But basically, you have all these blood vessels covering up the structure that it's supposed to, so that it's not functioning well and causing glaucoma. Oh, we talked about macular edema. Here it is. Here's a picture of the macular edema. Remember the OCT where it's nice and smooth? Well, this is not a nice and smooth OCT, right? This is an OCT that has all these black spots. So that's swelling. This is not supposed to be there. That's basically fluid, okay? And then these little white things that we see, that corresponds to these things here, which are exudates. And then you can see, and this is a tiny little microaneurysm. So what I'm trying to point out is that you can see that there's different diseases are affecting different layers of the retina. And that's why the OCT is so helpful. Let's see. Is there a procedure that removes blood from the eye? Yes, that's called the vitrectomy. And I'm going to show you some videos of that. So how do other comorbidities affect the progression of proliferative diabetic retinopathy? Basically, it's kind of a cardiovascular disease in some ways. There was studies that were done a long time ago, essentially, that if you have high blood pressure or your blood pressure is not well controlled, well, then your diabetic retinopathy will progress faster and be harder to treat, essentially. So I think that's essentially true. You kind of see people who it's hard to see people with end-stage diabetic eye disease who don't have some type of other cardiovascular risk factor. It's hard to see that. They often kind of go hand in hand, even though they're different diseases. It's the people who tend to have um, severe diabetic eye disease tend to have other cardiovascular risk factors as well. That's not to say there are some people with type 1 diabetes that have really bad eye disease that don't have those other things, but typically they have it all together. Is glaucoma related to blood vessels accumulating over the retina? No, glaucoma is the strict definition of glaucoma, which is another subspecialty in the eye, is damage to the optic nerve. So the nerve that connects the eyeball to the brain. If that nerve gets damaged, that's glaucoma. So this is the nerve. If this nerve gets damaged, that is glaucoma. And you can tell, there are tests that you can do, but just on exam, you can tell because this nerve will become kind of pale and cupped out, as in when you look at it, instead of this is healthy, nice and pink, it looks good. It's like a shallow bowl. If you had stereo, if you could see depth perception, which you could typically when you look inside the eye, this will be like a shallow bowl. But in glaucoma, it's like a deep concave bowl, and you can actually see like the nerve being really cupped out and like very deep. So that's technically what glaucoma is. Now, there's different causes for glaucoma, but one of the main causes is high eye pressure inside the eye. Okay. And there can be different causes for the high eye pressure. Some people are predisposed to it because of their anatomy. And then some people have diabetes. And that diabetes, the blood vessels that we talked about, the bad blood vessels that form, plug the drainage system of the eye. Basically, it doesn't allow the eye to deflate a little bit. You can think of it like that and causes glaucoma in that way. That's typically very bad. Are these actual people's eyes? Yes, these are eyeballs, not AI generated. So, what's the yellow ball in the background? This ball? This is the optic nerve. Is there another ball? This is the optic nerve. And then if you're talking about this thing, this is a ring of exudates, okay? Um, because it's basically leaking. Exudates are just like lipids and stuff like that that leak out of blood vessels. All right, so shocker, for diabetic retinopathy, you also do eye injections. Now, you might do different eye injection, different types of eye injections, aka different medicines, and you might do them with a different sort of strategy. But overall, one of the main ways that we treat diabetic eye diseases is with eye injections. We also can do laser for the retina. This is focal laser. Basically, this is delivering laser spots to the macula, which isn't all that common anymore, but they used to do this. But you can also do laser to the periphery of the retina for new blood vessels. Oh, like this. This is quite dense laser. You see these little white spots? This is fresh laser that has just been delivered to the eye, like literally a laser beam. Like you look at your patient sit there, and then I put a laser spot in their retina. Okay. And then this is what happens when the lasers sort of age. This is no longer fresh retina. This is sort of like kind of scarring. So this is what you might see in somebody who has treated diabetic retinopathy, although, I mean, I'm still seeing some scar tissue over here. So can injections into the eye cause damage? They sure can. Anything that's sort of an invasive procedure comes with risks. And one of the main things you have to do as a doctor is not only is to counsel your patients and also just mentally think yourself about the risk and benefits. So we talk about risk benefit alternatives and indications. So you want to always talk to patients about why it is that you're doing these eye injections. Okay, they're to help you see better, to keep you from seeing worse. Are there alternatives? Sometimes alternative to the injections is to do laser. Sometimes there are no alternatives. And the risks. The risks to injections themselves are actually fairly low. Of all procedures done out there, the risk of an eye injection complication is excruciatingly low. So the biggest risk that you can have is actually infection. So, it's a tiny percent of people who have infection. But if they do get an infection from the eye injection, it is fairly serious. And it is something that I counsel patients on sort of heavily, give them an emergency phone number they can call if they have issues afterwards, because time is sort of critical if they have signs of an infection. Does optical surgery leave bruising on the eye like plastic surgery? So, you know, it's hard to I'm not sure I told. So let me clarify. So, if you're doing surgery on the retina, and I really want to show you some surgical videos if you guys are interested. Um, you can see that the eye had surgery because there's going to be swelling and there's going to be blood sort of on the white part of the eye. And there might be some swelling along the outside of the eye. And that's mostly because you had a lit speculum, something holding the eye open, and you just kind of mucked around with the eye. So you might not have bruising, um, like as in like a black eye, but you have indications that you had surgery. Now, some surgeries like cataract surgery, the cataract surgeons have honed their skills so well that oftentimes you can barely tell surgery was done. But unless you look closely. What is the purpose of putting laser in the eye? There's different purposes. The primary purpose for something like this, which is called panretinal photo pan panretinal coagulation, right? Panretinal photocoagulation. There you go. It's spelled out on top. um, is that remember how I said that when you have diabetes, your eye enters sort of an ischemic state, as basically the blood vessels don't work really well. You don't get a lot of blood flow to sort of certain parts of the eye. And because of that, the ischemic retina produces growth factors, mostly VEGF growth factors. And these growth factors are what causes the new blood vessels to form. So what you do is you actually kill the dead retina. It's like strange, right? So you basically kill the dead retina so that this retina doesn't produce the growth factors, which can cause new blood vessels to form. That's the point of the laser. Have you ever added laser to the iris? Uh, no, not on purpose. So sometimes you zap the iris a little bit. You kind of hear a little spark when you're doing this laser because you're trying to get to the edges. Not harmful, but sometimes patients will hear a little zap. Um, but no, you can't do laser to the iris. I totally forgot. Not for the retina, but you can do lasers to the iris for like glaucoma reasons. There's a type of glaucoma called angle closure glaucoma where um, basically the shape of the iris makes the eye pressure um, increase really high, and then you can do laser to basically create a hole and allow a conduit of fluid to go through the eye that can lower the eye pressure. So yes, you can laser the iris. It's a different type of laser, completely different type of laser. But um, what is the most invasive an eye surgery can get, given its vulnerable nature? Um, I'm not sure how to answer that. I don't think the eye is vulnerable. I think the eye is, it's just another organ. You have to be more delicate. So we use very fine instruments and, you don't push on the eye and you manipulate it um, gently and delicately. But you can go into the eye, you can cut the eye, you can do a lot of things in the eye. You can take off scar tissues, which are just microns in thickness. Um, so anyway, I'll just go through this really quick so I can show you a video. I don't really know how much time we've spent at this point, but I'm just talking. So this is like the gel-like substance, the vitreous inside the eye. We talked about it, but it's kind of like it's clear when we're born, but over time it has like dirt look like stuff. You guys can probably see this yourself, okay? So if you go to a lighted room and you stare at a white wall or something, you can probably see these little strands in your vision. Okay, everybody has these. These are your friends. They're not going anywhere. If you focus on them, you're going to see them forever. If you don't focus on them, you can live your life just fine and not notice them. But as you age, they kind of get more and more obvious, and patients can sometimes complain about them. I always tell people, like, most people can get used to them. There's a small percentage of people that can't get used to them, and for those people, we can do surgery and just remove the vitreous, frankly. Um, Yeah, more pictures of the eyeball. So I'll just show you what a retinal detachment is. So this is the edge of the retina. Okay, we have the macula, which is the center of the retina, and then you have the edge of the retina. And then here you have a tear in the retina. Basically, the retina is broken. There's a giant tear in the retina. And because there's a giant tear, oh, here's another tear. The retina is detached. So the retina is the wallpaper that's inside the building, and you now created a tear in the corner, and because the tear in the corner, like basically the whole wallpaper is falling off. And that is like a kind of, depending on the retinal detachment, kind of an eye emergency and definitely needs surgery to fix. So here's just a little tear without a retinal detachment. And if you have a little tear without a retinal detachment, you can do laser. These are lasers again, okay, to kind of tack it down. But if it becomes a retinal detachment like this, you need to do surgery. See this little tear here? See this retina? Basically, the wallpaper has come off. Okay, the wallpaper has detached. This wallpaper attached, wallpaper detached. So just some more pictures. We have a lot of pictures. Here is a very big detachment. This is kind of giant retinal tear where like the retinal tear is like humongous. It's greater than a quarter part of the eye. And here is how we do surgery. This is not me. This is some guy I got off the internet. But we kind of sit like this. I sit at the top of the head. Usually the patient is draped a little bit more so that their neck is not showing, but I don't know. This just doesn't seem, but you kind of sit there at a microscope is the idea, and then do surgery. I don't think this is a real surgeon because this is not even sterile over here. But anyways, but you get the idea. They're sitting there, they're doing surgery, and then oftentimes you have an assistant that kind of sits on your side and kind of helps you. What causes a retinal detachment? Um, Many different things, but the primary thing is a retinal tear. If somebody gets a retinal tear and that happens, some people are predisposed to it, some people can get trauma that causes a retinal tear. But if you have a retinal tear and that tear is not treated fast enough, it can become a retinal detachment. And for those people that have issues that does, no, removing the vitreous really doesn't cause a problem. The vitreous is kind of there um, during like embryogenesis, like when the eye is formed in utero and all that stuff. The vitreous is useful to help the eye grow, but as after you're born, it doesn't do too much. So removing it is not a problem. Here's some more surgery. Sometimes we put a band around on the outside of the eye to support it. This is one type of surgery that we do. Um, I'm just gonna go through these a little quicker because I want to be cognizant of time. This is what's called a macular pucker. It's basically, remember the fovea that's nice and smooth? Well, this is not smooth. This is not smooth because you got the scar tissue that's on top over here. You can see it here as well on the macula. This happens with age. Some people just have it. And this can cause distort your vision. And what we do during surgery is we go in and we remove the scar tissue. Um, yeah, so you can see like you're basically going into the eyeball with tiny instruments, and you're removing a very, very thin piece of scar tissue. This is actually a macular hole, not an epiretinal membrane, but it's the same idea. You're peeling something off of the macula. And this is a macular hole. It's literally a hole in the macula. Like remember the OCT? There's it's a nice smooth but connected space. Now there's a giant hole here. There's literally a giant hole. Um, and this can happen, and when this happens, you can't see, so you got to try to fix it. Oof, this went a lot longer than I thought. I'm seeing 71 minutes over here. Um, so you tell me what you want me to do. Um, do you have any other questions, or you want to see one video, or I
Well,
don't know.
first off, thank you so much. I loved your lecture, and I also have done like anatomy dissection of eyeballs, and I like, kind of loved the refresher and seeing kind of all your pictures. I think everyone would love to see a video if you want to do that, and we want to be kind of time oriented and make sure that we're not wasting too much of your time. So if you wanted to pull that up, you're more than welcome to. Usually we just do Q&A now, but you kind of answered everyone's questions. So you probably have another 10 minutes if you wanted to play something. You're more than welcome to do that. Or if anyone has any more questions, you're welcome to ask for questions as well.
All right, let's try this. Are you guys seeing this or?
Yes, perfectly.
So you know how there's YouTube? Well, there's also iTube. Okay, iTube has a lot of videos. And I just pulled this one kind of randomly. I have my own videos too, but they're don't this one was just nice and easy. So I'm just gonna This is by those two surgeons. So just to orient you, this is the eyeball. I would be basically sitting up here at the top of the eye. Like right over here is the forehead. Okay. Above here is the forehead. And down here are the chin. So the bottom of the screen is the top of the head, if you're seeing the patient laying down. And the top of the screen is this would be where the nose is. I hope people are oriented. So basically, what you do is you keep the eyeball open, you clean it and all that stuff, and then you put 3 ports, standard ports into the eye. You have this little port over here that's connected to infusion, which basically keeps the eye inflated. Okay, this is important because you're doing things inside the eye, you're taking things out. This is sort of like I'm trying to think what the analogy would be to other parts of medicine, but this is basically what keeps the eyeball inflated. Very important. And then you have 2 little ports over here. This is where we put our little instruments in to do surgery. So it's basically a minimum, you can consider it like a minimally invasive surgery because it's not like you're taking the eyeball out of the socket and then you're cutting the eyeball up and you're sewing it back together. You basically can do surgery, retina surgery, without using any sutures or any major incisions. So you operate through these 2 little holes. And let's see.
The Dork Ava 23 gauge vitrectomy platform.
And now,
gauge vitrectomy platform was used.
I'm gonna get rid of the sound. So now we're inside the eyeball. Okay, we have put our little instruments through the holes, and we are looking into the eyeball. So remember, here's the optic nerve. I think the eye is so diseased, it's hard to tell. I think this is the optic nerve, and then these are blood vessels, and this is the scar tissue that we're seeing from diabetes, essentially. So what the purpose of this surgery is to try to remove some of the scar tissue so that the retina can flatten. Because we talked about causes of diabetic or talked about causes of retinal detachment. Well, one of the causes of retinal detachment is actually scarring and from diabetes. It's separate, it's a different cause than the retinal tear I talked about, but here it is. So you have one thing that's a light pipe. It basically illuminates so you can see what's happening. You have like a little flashlight. You hold a little flashlight, and then the little other instrument is basically going around and cutting. Okay, it's a little thing that makes pulses and things like that. It cuts things. And then after you cut a bunch of vitreous, then you can see here, this is a little forceps. Okay, they're taking this little forceps and they're kind of like lifting it. Basically, all these different techniques. The goal is to get rid of the scar tissue. It's actually it's quite challenging because the scar tissue is very adherent to the retina, and also the diabetic eyes can really bleed, which can cause a lot of problem. So I just kind of wanted to show you, like, this is the view that as retinal surgeons we have. We don't directly touch the retina, but we touch the retina essentially through little instruments. Here's a little pair of scissors that are being used to sort of cut the scar tissue off. And, they can be kind of challenging. Over the end. Oh, here's laser. So after the retina, you remove the scar tissue, you flatten the retina, you do laser. So you can do laser inside the eyeball. And then you fill the eye with fluid. And then you literally just take these little things out. So, for the student that asked about bruising and such, yeah, there's a little bruise, like you can call these bruises. And the eye has a little edema, a little swollen, but overall the eye looks pretty good. Okay. So that's one. Let me see. Here is a more straightforward, like the diabetes case, those are hard, those are not common. Sometimes some people don't even do them, frankly. But this is one that most retina surgeons will do, and it's a macular hole, okay? You'll see that this eye is a lot more normal looking. Oh, so this is the person that created this video. So here's the hole. You can see the hole, right? Very similar to the picture that we saw. And our goal is to basically, you'll see, peel a layer of tissue that's usually 1 to 2 microns in thickness around the hole. So the retina is clear, so we have to use some dye in order to visualize it. So that's what this dye is. It's like it helps you see things. So you can see that now it's kind of tinted blue. So you see this? You've got this tiny little forceps that's being used to remove this 1 to 2 micron thick tissue around the hole. Okay. So then you move it, and then now it's going to show some more advanced techniques doing different things that we don't have to go through. You can look at it if you want, but it's not typical macular hole technique. But that's kind of the idea. That's retina surgery. You're typically in the dark because you really want the lights off so that you can see everything as well as possible, and you're sitting, so you're not really standing. None of that like standing type of surgery. You're sitting. Let's see. So the eye does have an immune response. You can't get inflammatory. You can't get inflammation afterwards, and you want to really treat the inflammation if it does happen, because inflammation by itself can cause damage to the eye. How are you able to see inside the eye? So we are able to see inside the eye through a microscope. Basically, that picture that I showed, the guy is like sitting there looking, and then the microscope is basically focused onto the eyeball. Are there long-term consequences of this surgical procedure? So it's hard for me to answer that because I hope so. I hope the consequence of the surgical procedure is that the eye will see better. If you're talking about are there like risks to surgery? Yes, there's definitely risks to surgery, and surgery in general is sort of the last resort. If you can fix the problem with injections, lasers, lifestyle changes, whatever it is, if you can fix it using those methods, you definitely want to do that first. But if you can't fix it, then you basically have to do surgery. And surgery does come with risks like infection, inflammation, need for additional surgery. And, freak things happen. The only way not to have complications in surgery is to not do surgery. And sometimes bad things happen. Even a very predictable surgery can have something unpredictable happen. If you do enough surgery, it's going to happen to you. So yes, so you definitely want to counsel, and bad things can't happen. What is eyesight like for the patient once they wake up from these surgeries? So interestingly, patients are most of the time awake during surgery. We do monitor anesthesia care. So patients, unless they have a lot of claustrophobia or other comorbidities or something, most of them actually are awake. You give them medicine to help them feel kind of relaxed and comfortable, like a colonoscopy, and then you kind of do surgery. Sometimes patients will even talk to you, but so you have to be careful what you say during surgery because they can hear you. But it depends. What their eyesight is like after eye surgery really depends on what is done. Oftentimes for my surgeries, the eye is patched, so they basically see nothing. Sometimes they can see a lot better the next day. Sometimes they actually see worse, depending on what you're doing inside the eye. So there's a big range for it. If you're unconscious, does the eye still respond to light like normal? So when your eye responds to the eye, you probably mean the dilation, the pupil, right? Like that's what I think you're talking about. It's when you're in a bright light, your pupil will constrict, and in dark, your pupil will enlarge. And that is to let in light when you're dark, and then constrict and keep out light when when there's a lot of light. So whenever we're doing retina surgery and oftentimes cataract surgery, we actually want the pupil to be maximally dilated. So we actually give eye drops. So if you ever go to the eye doctors and they do a dilated eye exam, they give you eye drops. The idea is to get your pupil as dilated as possible. So the bigger the hole is, the easier it is to look in. So so it definitely does not respond to light if it's maximally dilated. How difficult is it to accurately insert instruments to go in the port to pull out something like scar tissue in the eye? It's so we often don't pull out scar tissue. There's an instrument in there. Basically, you remove the scar tissue and then you kind of pulverize it and eat it up. So it's unusual for me to take things out of the eye. Usually I deal with it inside the eye. It definitely takes expertise and it takes a steady hand. But it's not something that if you are inclined to procedural kind of tasks that you can't do. Like it is sometimes like when I first started doing surgery, or retina surgery, I was just kind of shocked by the human ability to basically go in there and then grab something that's 1 to 2 microns in thickness and not puncture other things that are like 200 microns in thickness. It's almost like insane that the human is able to have that level of control of your hand to do that, but most people can do that. So, thoughts on LASIK? I am not a refractive surgeon. Remember how I said that I don't do glasses? I don't do LASIK. Not like I don't condone LASIK, but I don't do LASIK. I only do the retina. Um, so is there a good prospect for the use of robotic systems to perform eye surgery due to the need for high accuracy? So, interestingly, there's several systems sort of in place, and I think in Europe they're I mean, I think there's several systems that actually have been done on have been trialed on humans for robotic surgery, cataract surgery, and even retina surgery. So I think people are working on that, and they're working on that in different ways, right? Because sometimes what can happen with a surgeon, depending on different things, it can be stress, it can be, you had a bad night, whatever it is, you can get a tremor. That can happen to some people. You can operate through a tremor if it were to happen, but obviously if it doesn't happen, that's even better. Or if you can reduce tremors, that can probably make things safer. So there's definitely robotic systems out there that can kind of steady the tremor. How do surgeons determine where to put the ports in? Well, that's part of surgical teaching and surgical learning about where to put the ports. It depends on a lot of factors. Depends on what kind of surgery you're trying to do, how big the nose is, how big the forehead is, because they can kind of get in the way of your instruments. Have you ever heard of Ortho K? Yes, I have heard of Ortho K. Again, not retina. So Ortho K is typically what people do. Remember how we talked about myopia? I think it's mostly myopia, rather hyperopia. Myopia, how the eye is really long, and you can basically it can be long because of the sclera, or it can be long because of the cornea. So Ortho K is basically these hard contacts.
Do you know where? Sorry.
Okay. Ortho K is basically you wear these hard contacts overnight, and the purpose of the hard contact is to push your cornea flatter, so that when you wake up, you can take out these hard contacts and you basically can see without glasses or contacts. My little cousin had them for a long time. I'm not sure I'm a huge fan, but um, because there's a sort of a corneal ulcer risk, and there's a lot of other options out there, frankly. They can predispose to an infection because you basically don't want to wear contacts overnight. And I'm a contact lens wearer, so you really don't want to do that because you can get contact lens corneal ulcers that are very bad. Yeah. Well, this was really fun, guys.
All
Do
right,
you have
if
any?
there's no other questions, we can move forward. Um, I assume there's not. If anyone
No?
else has any questions, they can always just kind of last minute throw them in. And maybe Dr. Chen wants to stick around and see if there's anything. But we do want to be mindful of your time. So if you do need to go, you're welcome to. We just want to say thank you so much for your informative presentation. I know that we've all learned a lot, and I loved seeing iTube. I'm definitely going to be on there. Um, so
Oh,
if you can turn off your screen share, I will share my final presentation.
one second. Did I
No,
stop sharing? No.
nope, I still see it. Lots of thank yous.
Oh, here it is. This big red button that says stop share. All right. Cool,
I
guys.
was,
Really great to be here. Best of wishes, and bye.
thank you so much.
No problem. Have a wonderful evening. Now I
Yeah, you as well. Okay, I will go ahead and finish up our presentation. So I'd like to encourage everyone to reflect on their session today. I usually say that that's what brought you here, what are your three main takeaways, and what do you want to learn more about? You're welcome to send this to us at info@prehealthshadowing.com. Sometimes we do post these reflections along with your kind of name on our website, and that can kind of give you some more kind of recognition or publication on our website, and see how other people view your writing or your kind of session review. You do not need to send these to us, and you don't need to do this. This is not a requirement at all, but it is something that's nice for some people that like doing that. We'll keep going. So if you do want to share those as well, you can also share them on our LinkedIn. It is our professional social media platform. If you share them on there, we oftentimes will go ahead and like those. You can also follow pre-health shadowing and repost things. We do repost some of the people's reflections on our page, and then other people can see those as well. So it kind of gets you more involved in our program. So again, if you're interested in being part of pre-health shadowing, we do have volunteering opportunities and leadership opportunities. There is some research opportunities on there if you want to go ahead and get more resources on that or understand how everything works. It's always welcome to go to our website at prehealthshadowing.com. And again, that's 100% remote. You don't need to go anywhere. Everything's online. You can ask questions. You can talk to anyone on our team. We are very open to discussing opportunities or options or what skills you have to bring to this opportunity. So if you want to learn more or get involved, you can always go to our website or even our social media and ask those questions. We're happy to answer anything. We are also accepting team member applications right now, just to throw that out there. So once again, we are humbly asking that if you can financially donate, that you consider sending us a few dollars. We also have a Venmo or a PayPal if you're interested in that. It's on our website. It does help us keep the program up and running and free for everyone who cannot donate or who even can donate. And then that's through our website or this QR code, either or you can donate that way. And if you can't financially support any of that, you can always provide it to your friends or family that maybe can donate and help us keep running. So now what you've all been waiting for is how do you earn your digital certificate for attending? So you have to take a post-shadowing assessment. That'll probably be up in the next 15 minutes or so. So I don't recommend you blast our email if you can't get on right this second. It will be 10. There are multiple choice questions. Some of them are true false questions. Usually there's not a lot of multiple choice. They're more single choice questions through multiple choice. You have 2 chances to pass it. You have to have 70% or higher, so 7 correct, 3 wrong, to get your virtual shadowing hours. If for some reason you cannot answer the questions or some kind of technical difficulty comes up, feel free to email us. We can also help you in getting your certificate that way. We are open to indefinitely, so you can take these quizzes whenever you want. You don't have to take them right now or in the next hour. You can take them a week from now, a month from now. All of our sessions are recorded and they will be on YouTube and on our website. You can also go and watch past lessons or past sessions, and you can see how those fit into what you're excited about and kind of learn more about from those for professionals. It's not the same as live. You can't really ask any questions. Sometimes the professionals will provide their email and be open to conversations, but another way is to just go and listen to their lectures and see if there's something that fits kind of your pre-health shadowing. So all you have to do is go and find the same place where you found how to access this link, hit the take the course, and then there should be a little quiz button that you can open that. And so once you finish, you will be able to download a certificate. Make sure you keep track of all those certificates. And then if you want, you can also go and look at our upcoming shadowing sessions, and you can register for those, and then you'll get an email that will tell you when that's going to come up, and if it'll remind you of, so you don't have to miss on any of that. So, but if you did miss on any part of this session, you can visit our YouTube or our website at prehealthshadowing.com. On our YouTube, you can also just type in pre-health shadowing and then type in any topic you want. I know someone was talking about OBGYN. You can always just type in pre-health shadowing OBGYN videos, and then they'll have every video that we've had in the past for OBGYN. Those are welcome for you guys to watch those, and then you can go to the website and find that doctor's page, and you can take that pre-health shadowing certificate quiz. That should be linked in the video below as well in the comments. So if you missed anything, you can also go and find this lecture will be up probably within the next 24 hours. And then you can go ahead and watch if you missed a section or if your Wi-Fi was kind of spotty and you didn't really get to hear anything. And then you can go ahead and take the shadowing assessment. So be sure to catch our sessions. We do have one, I believe, next week with a PhD candidate who's outstanding. But if you guys want to learn more about that, you can go to prehealthshadowing.com and you can see their page and read about them. And on Instagram, we usually post a little mini bio video that will explain that person as well. So be sure to follow us on social medias or our email list and see our upcoming sessions. And thank you for joining us today. I will stick around if you guys have any questions about our program or all of our opportunities. I'm welcome to answer any questions. And if I don't know the answer, I can always send you to someone who does. I'm also happy to have any of our other members who are in the chat right now answer those questions as well. And I would say that this is officially over. So if you guys want to leave, you're welcome to leave. If you want to stick around and ask a question, you're more than welcome to. You can raise your hand or you can just type it in the chat. Have a good one, guys.